Welcome to another EduMed video, and this is another in this series going through the NHS England document for the management of patients with COVID-19 in critical care areas. And we'll be focusing on respiratory management of patients in this part. Specifically, we'll be thinking about the basic respiratory management, and this includes NIV and CPAP and high-flow oxygen therapy. As I say, it's based on the clinical guidance that was produced by NHS England, and this was published and updated on the 8th of April. And I think there are a few key points here that's worth highlighting, both for critical care management and also for the management of patients on the wards. We'll be talking a little bit about oxygen therapy, then about high-flow nasal oxygen and CPAP NIV, and both of those modalities being used quite a lot in other countries like Italy and China and even Spain. However, in the UK we've been using them less, mainly from the standpoint of trying to minimize the amount of oxygen demand and also trying to minimize viral spread, because both high-flow nasal oxygen and non-invasive ventilation or CPAP have been associated with as aerosol generating procedures and thus may be exposing healthcare professionals to higher viral loads. So there's a few things to highlight when in the first part when they talk about oxygen therapy. And I think this is a really key point, which is to avoid hyperoxemia. And I think if we have a look at that, anybody who has too high a fractional inspired concentration of oxygen, they will increase the oxidative load on the lungs and therefore increase the risk of things like lung fibrosis. So try and reduce the oxygen down to what is required. And I would go back and watch my video where we talked about the aims for saturations, and the NHS England guidelines are suggesting saturations of 92 to 96%, and in some patients lower if they've got chronic lung diseases such as COPD. It is important to bear in mind that the safety margin when targeting slightly lower oxygen saturations can be significant, especially on patients who are on the ward who aren't as intensively monitored as those patients in critical care with 1-to-1 or 1-to-2 nursing. Please go and have a look at my video on the guidelines for oxygen targets, because I talk a little bit about the oxygen dissociation curve and about the precipitous drop in oxygenation when you get to around about 90 to 92%. And that really explains why you can target the slightly lower saturation targets of 90 to 93% if they've got continuous pulse oximetry. And they really do mention the fact that it should be appropriately monitored. I think that's really important because you are sitting on the shoulder of that oxygen dissociation curve. Again, please go and have a look at my other video. In a lot of countries, such as Italy, Spain and others, there have been situations where the oxygen demand on the oxygen supplies in the hospital have been so great that they've caused failure. This can be difficult to predict, and even if you've got enough oxygen, if you've got too many demands on that oxygen, the pressure and the total flow may reduce. And as such, you could get into a situation where you have total oxygen failure and none of the ventilators work, none of the CPAP or high flow oxygen works. And so a lot of the work that's been put in has been thinking about what clinical targets are actually appropriate and also what's practical, bearing in mind the slightly higher oxygen demands that are going to be put on the hospital. It's really important, this last point, about making sure that oxygen flow meters and high flow devices are switched off. The reason that's important is it happens very easily, and we often forget when we intubate someone, we leave the water circuit on with oxygen flowing through it. Make sure everything is switched off, that's not being used, because every last drop of oxygen really will count when the pandemic hits and the oxygen demands in the hospital increase. You don't want to be wasting oxygen. Now, in the NHS, they are suggesting that we avoid high flow nasal oxygen if there's a potential problem with the supply of oxygen. If you've got loads of patients on 60 litres per minute of high flow nasal oxygen, you are going to run out of oxygen in the hospital relatively quickly. So that's a bit of a logistical thing and does depend upon how your oxygen supply is delivered to the hospital and how reliable and robust it is. Some of the bigger hospitals may not be so much of a problem. Some of the smaller hospitals with smaller VIEs may well come into problems where they run out of oxygen if they use high flow oxygen too much. The other really important thing to consider is the risk of aerosolizing the virus. Now, there were some studies, admittedly done by Vapotherm, which suggested that aerosolization wasn't that great if you placed a surgical mask over the nasal high flow system. I'll be honest, I would consider this a aerosolizing potential procedure, and we definitely know that the higher the viral load that staff are exposed to, the greater the risk of them developing severe viral disease. So I think for the safety of everyone around you, and that's the nurses, the doctors, the physios, the dietitians, the pharmacists, and other patients, I think we have to be very careful before starting patients on high flow nasal oxygen. The guidelines themselves talk about considering using them if you've got negative pressure rooms or neutral pressure rooms, inside rooms, and not doing it on open bays. I think that's a bare minimum, but we do have to be careful. Then let's think a little bit about CPAP, and I think all of us are now quite used to seeing the CPAP hood pictures that we've seen in Italy, and they've managed to stave off intubation for a number of patients by using CPAP, so I think it's definitely got its place. They do mention that we use non-venting face masks, and I think that's the first thing to really highlight, because a lot of us are used to using NIV masks with a little hole in the front of it, usually at the angle piece, that vents the exhalation gas out into the atmosphere. We can't have that in COVID patients because then you're just aerosolizing huge amounts of the virus. Therefore, what we suggest is either having no exhalation limb or having an exhalation limb where you can attach an HME filter. In Italy, certainly, what we saw a lot of was the use of the helmet. And the nice thing about the helmet is that you can put a HME filter on the exhalation port and therefore stop aerosolization of the virus. Now, like I say, in a number of hospitals, and there's been now a number of papers suggesting that we can stave off invasive mechanical ventilation by using CPAP. That's certainly true. However, we do have to balance that with the increased oxygen requirements required for some of the systems that provide CPAP, and also considering the risks to other patients and to staff members through potential aerosolization. I think it's really important. I think actually, to be honest, every patient that is on acute NIV or acute CPAP should have these things, and that is continuous pulse oximetry, because we've already got into a situation where these patients have respiratory failure that has failed simple oxygen therapy, and as such these are critically unwell patients whichever way you cut it. So they should all have continuous pulse oximetry, and they should be in an environment with trained staff to monitor them for deterioration. And we do have to look for deterioration. We know that some of these patients very rapidly deteriorate off CPAP, and the only option you then have is to intubate those patients. And you're often getting to intubating these patients at a much later stage than if they had just failed simple face mask oxygen therapy. Patients who have failed to respond to CPAP trials are also important, because what that indicates is that if they haven't improved with CPAP, they're running on the edge. And so having a low threshold for intubating those patients, I think, is important. So The key thing with CPAP is once you've started a patient on it, watch them for a few hours, make sure there's been an improvement, make sure you can reduce down your FiO2. If you can't, then you need to think about invasive ventilation, because these patients are teetering on the edge and they will likely deteriorate. Now, depending upon the systems that you have, you may be able to do low flow CPAP. And what this generally involves is using a CPAP machine where you can entrain some oxygen into it. Now, it's not quite sure how much oxygen we give, depending upon the system that you use, but some of them you can just entrain a couple of litres into the limb. Now, this is sometimes difficult to do, and you need to have the right equipment to do it. And so that's put in there. I think it's useful for those patients who don't need a lot of oxygen. However, we just need to be careful because you're not quite sure how much oxygen you're giving in these situations. Now, what you will find, and certainly what I've found, is that some patients with bad COVID disease, but actually not that bad, do seem to improve quite dramatically after just short periods, 1 to 4 hours of CPAP. And especially if you're using a form-fitted face mask, it can be tough to do longer periods, especially if patients feel claustrophobic. The hoods aren't used in the UK that much, and I must admit I don't have much experience with its use, but certainly people say that they feel much less claustrophobic using them, and they do seem to tolerate them for much longer periods of time. But I think it's important to try and build in some breaks when you're using CPAP, but also always looking for those signs that the patients are improving with CPAP and therefore it's worthwhile continuing with it. And those things to look out for is a reduction in the FiO2, a reduction in the respiratory rate, and I think probably most important that we're seeing with COVID, and one of the markers that I really hold dear is looking at work of breathing. If the patients are chugging away, even on CPAP, it's a bad sign, and I would have a low threshold to intubate those patients. If, however, you see these patients completely comfortable when they're on CPAP, I think it's probably worth continuing on and avoiding mechanical ventilation with its inherent risks. I think we do have to be careful about using CPAP or even NIV, non-invasive ventilation, as a way of preventing intubation. There are some patients for whom it's clear that they need intubation, and I think if patients do look like they're critically unwell or that they're not responding to CPAP, you must intubate these patients early if you think it's appropriate. There's no point in waiting. There's good evidence that these patients just continue to deteriorate, which makes your intubation more hairy, and then the period immediately after intubation where you have to re-recruit these patients much more difficult. One phenomenon with COVID that we're seeing is that patients can look really comfortable even though they've got quite significant levels of respiratory failure. This is the so-called happy hypoxics that people are talking about. Now, although people act as if it's quite novel to this disease, we've seen lots of this in the past with flu, with SARS, with MERS and other things as well, even with just bad pneumonias. It's not that uncommon. The thing about COVID is that in the early phases, lung compliance is relatively normal. So actually, these patients can breathe away quite comfortably. But what you do need to keep an eye on is this high spontaneous minute ventilation. And I think the higher the minute ventilation, the more indication there is that things are going wrong. And that's for two reasons. Firstly, the patient may just be compensating for their degree of respiratory failure. So they may have minute volumes of 12 to 16 to even 20 litres per minute. And that not only shows that the patient is really having to compensate for the loss of their respiratory epithelial surface, but also it might be increasing those transpleural pressures and therefore potentially causing injurious ventilation, even though it's spontaneous, and thus causing more inflammation in the lungs and therefore potentially causing a greater risk for developing an ARDS type picture. So patients with high works of breathing, high minute ventilations, trial them on CPAP. If they've still got very high minute ventilations, I'd have a low threshold for considering mechanical ventilation, as much to try and protect those lungs from their inherent transpleural pressures being high. Now, this next point is something that I really, really strongly want to emphasize. And I think even if this patient does not have COVID, it is vital that any patient that you put on CPAP or an NIV should have a documented ceiling of care. This is an advanced type of ventilatory support, even though we class it as basic. There is a very small step from non-invasive ventilation to invasive ventilation. So every patient that you're putting onto CPAP or onto NIV, there should be an appropriate ceiling of treatment discussed with both the patient and the family. This should be done early, ideally whilst the patient's still able to talk, and by doing so you can prevent patients inappropriately being intubated and brought to intensive care. Now, I think it's important to note that bi-level ventilation or NIV isn't really needed for many of these patients. Failure to clear CO2 isn't really a feature of early COVID who require positive pressures with CPAP. You might, however, in some patients get a bit of a requirement for bi-level ventilation. That tends to be patients with type 2 respiratory failure that's chronic. So these are the COPD patients classically. I cannot emphasize enough that we need to protect our staff and we need to reduce the viral load in the air. And the best way to do that is by having antimicrobial filters on the expiratory limb of any NIV or CPAP device. And it's really important to be aware of the devices that you have on the unit, what their mechanics are, where the expiratory limb is, and make sure that there is a viral filter put on at all times, because otherwise you can quite significantly increase the risk of your colleagues and other patients in the vicinity from getting a high viral load and therefore potentially a more severe COVID infection. The guidelines are quite clear in that because of this risk of contamination, it's an aerosol generating procedure. If you can, put them in a negative or neutral pressure room. Something that's really important is to switch off the positive pressure if you're in a positive pressure room. Some people think that side rooms, if they're pressure rooms, are all negative pressure, but that's not true. Some are purely positive pressure and some can be flipped between positive and negative. Always double check before you put a patient in that room, and certainly before you do an aerosol generating procedure such as CPAP or NIV. We're recently finding that patients are really improving with proning, and there's a recent guideline that's been brought out for how to manage patients with awake proning, i.e. those on CPAP or on oxygen either through high flow or conventional masks or nasal cannulae. I've made a video going through the guidelines for this and discussing how to manage these patients, but I personally can speak of experience of using it, and it does seem to work in these patients where getting them to auto-prone does certainly allow us to reduce down the fractional inspired concentration of oxygen, both when they're on high flow or on conventional oxygen therapy or on CPAP. So definitely worth trying, and it may well help you to stave off invasive ventilation. In addition to using it to stave off intubation, there is also a role for using CPAP NIV for extubating patients. Now, one has to be careful because this is an aerosol generating procedure. Extubation is an aerosol generating procedure, and you have to ask the question, if you are needing to bridge a patient onto NIV or CPAP, whether actually they're ready to be extubated. Personally, I have quite a high threshold for extubating the COVID patients. I've seen quite a lot of them extubate, do well for a couple of days, and then deteriorate again and need re-intubation. Or I've had patients who have had a lot of upper airways edema and required re-intubation after a few hours. So if you're thinking about extubating them onto NIV or CPAP, I think your first question has to be, is this patient actually appropriate for extubation? And I would suggest having a high threshold for extubating these patients. So in general, the main things to highlight from this first part of the guidelines is slightly lower sats are appropriate, but always be aware of the caveat that these patients are on the shoulder of the oxygen dissociation curve, so any further lack of oxygen transference of absorption will cause quite a precipitous drop in saturation, so it needs to be acted upon early. So 4-hourly observations for these patients is probably not appropriate. If you're using high flow nasal cannulae or CPAP, be aware of the amount of oxygen that's being used. And also with both, but especially high flow nasal cannulae, there is a risk of environmental contamination. It is an aerosol generating procedure, and as such, you are exposing both surrounding patients and staff members to high viral loads. CPAP is useful, but make sure you've got the right equipment. You need non-venting masks or a helmet. They must all have continuous SATS monitoring, and please document an escalation plan before you put a patient on non-invasive ventilation or CPAP. If you can, consider low flow CPAP, where you're requiring a lot less oxygen and therefore protecting the oxygen supply within the hospital. And always ask yourself whether these patients look more comfortable. Has their work of breathing reduced once they're on CPAP? Has their minute ventilation reduced? And if they haven't, have a low threshold for intubating these patients. And finally, awake proning seems to be really helpful in this disease process, and probably most patients with severe respiratory failure. And as such, highly recommend using it. It can be done with NIV, it can be done with CPAP, it can be done with face mask oxygen. It can dramatically reduce your oxygen requirements, and it's fairly easy to do. If you're interested in learning how to do it, I've got a video that goes through the NHS England guidelines for how to do awake proning. I hope you found this video useful. The next video that we'll be doing will be talking about the more advanced methods of ventilation and the management of patients in critical care with COVID-19. If you enjoyed this video, please like and subscribe to the channel and hit the bell notification, and you'll be updated when more videos come up.